Next speaker up is actually a patron of CDH UK, but he's also a professor of fetal medicine and I think obstetrics, if I've got that right. Jan, are you there, Jan?
Yes, good morning. Thank you, Beverly.
Can I hand over to you for your presentation? It's wonderful to see you and thank you for joining us today.
Good. Thank you. Thanks for giving the floor to a gynecologist, indeed. But after my hours, I'm a fetal surgeon. And that will become clear as we speak further. So congenital diaphragmatic hernia starts already before birth. And as you heard from somebody earlier in the conference, not always the diagnosis is made before birth, but quite often parents face the diagnosis before the baby is born. And then, of course, a number of questions come up. So I'm going to speak about how we today can make the diagnosis before birth and why it is relevant. And how today we can individualize the counseling to parents based on measurements we do, how we speak with parents, and since a number of years, there is the option of prenatal therapy, and I will tell you about the outcome of trial that has been done on that. We also have a glimpse into the future, because the fetal therapy will definitely change. And that's all thanks to you, because you guys have been supporting our and other people's research in this field as well. On the right-hand side, you see a typical image of a baby that has diaphragmatic hernia. So in 2 out of 3 cases, in the United Kingdom, in a recent review, perhaps a little bit less, but certainly in 1 out of 2, the diagnosis before birth is made. And that is because we see the heart of the baby not sitting on the correct place because it's being pushed away by the abdominal organs. As you know, today women get the option of having a prenatal scan already in the 1st trimester. And it is indeed possible to make the diagnosis, but that is much less frequent, only in 1 out of 3, because of course the anomaly is not so easy to pick up that early. Now, when this happens, a roller coaster starts for these patients, these families. And what is extremely important is, at that moment, there is not really a medical emergency. Yes, there is a psychological emergency, but one cannot really tell parents what the outcome will be without a comprehensive assessment. And that needs to be done, and it needs to be done at a center that has a bit of experience in it. The diagnosis being made means also that the parents can be transferred to a center where the baby will be born in the most optimal conditions. That is the most important thing of a prenatal diagnosis, that the baby can be born there where the best care can be given. And that is probably not the local hospital. It's not good to transfer the baby after birth. Now, here on the left-hand side, you see an animation. And during pregnancy, through the hole, the abdominal organs come into the chest. And as they come into the chest, there is not enough space for the developing lung. Now, when we have made such a diagnosis, we want to rule out other problems. So all patients should be offered genetic testing. But once the diagnosis is made, a number of imaging studies will be done, and that includes ultrasound as well as MRI these days, to try to assess the individual size of the lung. And we do that in simple terms by measuring how much of the lung can be measured in the chest. And we express that to the circumference of the head. Babies with diaphragmatic hernia have a normal head circumference, but a smaller lung, so that the ratio becomes smaller. And there is also something that indicates the outcome, whether there is a big hole, meaning that there is place for the liver to herniate into the chest, and that is taken into the equation. And then we use this, and it seems rather complex, but it is not. At the bottom, one can see percentages. This is 15, 25, 35% of the normal. And on that side here, you can see the chances for the baby to survive with best care after birth. And so when the baby has a lung under 25%, the outcome is usually not good, with a survival chance of 20 to 25%. And then babies who have big lungs, already half of the normal, allows most babies to survive. And so this is a spectrum that we use to counsel patients. And it's good to know that the very severe condition is unlikely to happen. Only 15% of babies with CDH on the left side have that severe disease. In the middle, 1 out of 2 will have this typical intermediate or moderate disease. Now, when we have made the diagnosis, we try to offer the parents the best counseling they can get. That involves neonatologists who will take care about the baby after birth, surgeons who will make the surgery after birth. And of course, we also have to tell parents what it means to have a child with CDH, a growing up young adult, because this is a condition that may have long-reaching consequences. And I would like to thank the charity, in particular Beverly Power, who has helped now to write out a document for standardized way of counseling, so that parents can read up everything that they need to know about CDH based on very good data. And that is a paper that will be probably public in about 2 to 3 months from here. What is important is that we are good in predicting what will happen in the first days of life, but unfortunately, we are not so good in predicting the long-term outcome. And although that seems counterintuitive, it is actually not, because many of the things that determine the morbidities that may occur later on, those morbidities cannot be very well predicted before birth, because they're not only dependent on the lung size, but also of things that happen after birth during the neonatal treatment or problems that arise early in life. So that is a bit disappointing, but we can predict very well what happens in the first 7 days of life. Now, I'm mainly here to tell you about the potential of improving the outcome by doing an intervention before birth. And we do not try to repair the defect before birth. That is not needed. Pediatric surgeons can do so much better after birth. It can actually wait, because the real initial problem of the baby is having too small lungs. Now, to cut a long story short, there is a way one can make the lung grow. It is basically by inserting a balloon into the windpipe, which blocks the airways, and so the fluid that the baby produces before birth gets like trapped into the lung. It blows up the lung tissue, it stretches the lung tissue, and that's how it starts to grow. Now here, a bit of a complex slide, but I will guide you through it. In the black bars, you see the survival chances without an intervention. Now in that intervention, as I said, under local anesthesia, an endoscope, which is a small camera, is brought into the windpipe, and a balloon is being deployed into the airways. And one can see here real footage. This is the fetal mouth. And as you can watch further on the left, but when you do such an intervention, in the blue bars, you can see that the survival increases with this therapy. It increases by about 30 to 35%. The actual effect is dependent on the size of the lung. This is an operation before birth. Some babies get prematurely born by this intervention, and that's not a good thing for diaphragmatic hernia. So that can offset the effect of the therapy. And we also need to take out the balloon before birth not only for the baby to be able to normally be ventilated, but also because it induces lung maturity. So we really try to do that before birth. We know that we have improved the outcome not only in survival, but that we have also been able to reduce the morbidities that are associated to this condition. So like oxygen need, hospital stay, feeding, etc. We should not forget about the pregnant mother, of course. We have been studying the long-term effects, and we know this procedure is safe, and we know it doesn't compromise the future reproduction. So mothers can get pregnant again without any problem. Now you have certainly thought about how can we get the balloon out. Well, we sometimes do by puncture, 1 out of 5. Sometimes we use an endoscope. But if the baby would be born by surprise, so to speak, by preterm labor, we may still take the balloon out during a standard cesarean section. And you can see that how this is done in very well controlled conditions. But this is the weakness of this therapy. Mothers who have such an operation have to stay close to a center where there is 24/7 the skills and the people to remove that balloon. Because we have at the very beginning of our experience experienced that when mothers present at hospitals where that is not present, the baby may actually die with occluded airways because of the therapy. I will come back to that. You know that we, all these numbers are only numbers for what we call controlled studies, but not perfectly controlled. So when you don't know whether your new therapy is good or bad, you do a trial. This randomized trial was called the Total trial, and you can see the website there on top. And I can tell you that this trial has now been concluded. You see here all the centers participating, including King's College in the United Kingdom. So what happens is we make the diagnosis before birth. The patient in that trial was referred to a center where a balloon could be offered. And when the families were agreeing with trial participation, either the baby by the toss of the pregnancy was further expectantly managed by the toss of a coin. If the patient ended up in the group for fetal therapy, depending on the severity, the patient had a occlusion of the trachea at around 27 or at around 30 weeks, stayed in those hospitals until 34 weeks, and then was sent back and was managed in a standard way. So I can tell you that this trial has now been concluded. We cannot share the results yet with you because they are under peer review. But I can tell you that one of these trials was terminated early, was concluded early because of efficacy. So we now know that there are selected patients that will benefit from this therapy, and therefore in the future, that therapy will certainly stay amongst us. To finish, I would like to say we are working further on solutions to make it leaner, to make it easier. What you saw here is a magnetic balloon. A balloon that by external magnetism can be removed. So no new operation needed. This will change dramatically things because that means that mothers don't have to stay around hospitals where the therapy is offered. Your organization is very mild to us and generous to us. They have been offering us support to try to also work on a medical therapy, so that we could give tablets to get medication over the placenta to the lungs of the fetus. And what you can see here is that this is from an experiment, not in humans, but in animals, where we could ameliorate, improve the lung development by simple administration of Viagra, which you know from another use. And to finish, I think we now also have to work hard to try to predict much more accurate who is going to benefit from therapy before birth, what the outcome will be on the long term. And I'm so glad that you are supporting us in that work. This is the last slide to thank all the funders, but today I think I would like to thank you in particular. Thank you very much for your attention, and I hope I was clear.
Thank you very, very much, Jan. That was amazing. Thank you.